Good afternoon, everybody. Good afternoon. Hello. Welcome. It's a great pleasure for me to welcome you today to our Dean's Colloquium for this month. I do want to mention that this session is co-sponsored by the Gamma Mu chapter of the Delta Omega Public Health Honorary Society here at West Virginia University. And I do want to mention a little bit about Delta Omega. Delta Omega is the Honorary Society for Public Health. This was founded in 1924 at Johns Hopkins University, and today has over 100 chapters with more than 20,000 members in schools of public health. The society is dedicated really to the quality in the field of public health and to the protection and advancement of health of all people. In 2012, the Gamma Mu chapter of Delta Omega was established here at West Virginia University in the School of Public Health, and it continues a tradition of excellence. Our chapter, for the last 6 years in a row, has received national recognition as the chapter of the year for Delta Omega across the nation. So I just want to congratulate our students for all of their great work. And we're very pleased to have this session co-sponsored by Gamma Mu. Today's featured speaker is Dr. Julie Donahue, and I'll be introducing her in just a moment. But we also have two other invited speakers who will be joining us immediately following Dr. Donahue's presentation, and I just want to mention that so you all stick around for that part of the colloquium. First, Dr. Nathan Pauly, who is a member of our faculty, who serves as a research specialist within West Virginia Medicaid, will be talking about some of our ongoing work with Medicaid. And joining Dr. Pauly will be Dr. Jim Becker, who is a member of the faculty and vice dean in the School of Medicine at Marshall University, and also serves as the West Virginia State Medicaid Medical Director. And Dr. Becker will be speaking also about our partnership with the Medicaid program here in West Virginia. I also want to invite everyone to stick around following today's event. There will be a networking session here in this same room sponsored by Delta Omega, so refreshments will be available. Folks are pleased to stick around and mingle and network. And finally, for any student or faculty member who is interested in what we're doing with the state of West Virginia and our partnership with the Medicaid program, or our partnership with other parts of the Department of Health and Human Resources, and would like to learn more about that, we will have an open forum tomorrow morning beginning at 9:30 in the Dean's Conference Suite on the second floor. I invite you all to please stop by, hear more about what we're doing and how you can become involved in the partnership. So with all that, let me now move to introduce our speaker for today, Dr. Julie Donahue. Dr. Donahue is a professor and vice chair for research and co-director of PhD programs in the Department of Health Policy and Management at the University of Pittsburgh's Graduate School of Public Health. She's also the director of the Medicaid Research Center and co-director of the Center for Pharmaceutical Policy and Prescribing. Dr. Donahue conducts research on insurance coverage, financing, and delivery of health care with a focus on use of prescription drugs and behavioral health services. And we're delighted that she could join us today to talk more about the state university partnership between the University of Pittsburgh and Pennsylvania's Medicaid program. So please join me in welcoming Dr. Julie Donahue.
Good afternoon. Can you hear me okay? All right, great. So let's see, I don't know if anyone told me how to advance the slides. That works. Okay, very good. I guess I'm tall enough to see over the screen here. I'll try not to shrink down too much. So I was really excited to receive Dean Coben's invitation a couple of months ago. I've been down to West Virginia to ski, but I've never been to WVU, and it's obviously such a great institution, really a sister university to Pitt. I was also excited to come down here because I've had such an incredible interaction with some of the faculty members here. Nathan Pauly, Lindsay Allen, Tom Bias, Adam Baus have been wonderful collaborators in cross-state Medicaid work, and I've been privileged to get to know Dr. Becker over the last several months. So very, very glad to be here with you. I'm going to talk about a topic near and dear to my heart, that's Medicaid, Medicaid policy, and improving the strength and resilience of Medicaid programs. Just a brief outline for today's talk. I'll talk about Medicaid's role in securing the safety net for those of you not familiar with the program, a little bit about variation in Medicaid policy, talk about the policy of bringing evidence to policymakers in Medicaid, and particularly want to highlight the role of state-university partnerships, and finally talk about building a laboratory for evaluating Medicaid policy across states. All right, so just a little overview of Medicaid's role in our healthcare system. This is my favorite graphic that shows the multi-payer health system that we have, multiple insurance coverage system, and how the ACA went about trying to plug some of the holes left in this patchwork system. Down at the bottom, this is roughly to scale. You see Medicaid under the traditional rules around eligibility, and then that light blue expansion of Medicaid that some states chose to take on. Now a majority of states have taken on, including West Virginia. The basic tenets of Medicaid are, it is an entitlement program. So whenever we hear about constraints on the federal budget, this is certainly a big driver. It's an entitlement in two ways, both at the individual level. If you meet eligibility criteria, a state can't refuse to cover you under basic federal rules. There's also an entitlement that the states have to federal funding. There's a partnership between the federal and state governments to administer the Medicaid programs, with the federal government laying out a core set of rules, but states actually having quite a lot of flexibility in making decisions about the administration of the program. That handshake shown in the middle there is not always quite as smooth and harmonious as that handshake might project, but it is a partnership nonetheless. So this shows the growth over the last 10 years in Medicaid enrollment nationwide. We went from about 51 million people covered in Medicaid in 2009 to last year, the program covering more than 75 million. So it's larger than Medicare. It's a very large insurance program covering 75 million people, about half as many as are covered by employer-based health insurance in this country. This shows the percent covered by Medicaid in West Virginia by county, and you can see that it varies from 15% at the low end and up to 48% in some counties where Medicaid plays a hugely important role. And so you can think about the role that Medicaid financing plays in hospital budgets, in financing care at a local level. Medicaid covers a large number of people. It also plays a really important role for certain vulnerable populations. So if you care about child health, you should be interested in Medicaid. If you care about maternal health, you should be interested in Medicaid. Medicaid covers 38% of all children in this country. It covers about half of all pregnant women in this country. It covers a large number of people with disabilities, covers 20% of all Medicare beneficiaries who have low incomes and are dually eligible for both Medicaid and Medicare. If you care about HIV, you should care about Medicaid because it plays a large role in covering treatment for that population. If you care about aging, long-term care, Medicaid finances 62% of all nursing home stays in the U.S. This shows the role that Medicaid plays in helping to finance the safety net in terms of community health centers, or FQHCs. So in states that expanded Medicaid, the 55% of patients seeing in community health centers are covered by Medicaid, compared to 34% in states that have not expanded Medicaid. So that's an important source of financing for those safety net providers. One of the issues that I'm going to touch on throughout my talk today is the opioid crisis, and we know Medicaid plays a really important role in addressing this crisis. It covers about 38%, almost 4 in 10 individuals with an opioid use disorder are enrolled in Medicaid. And probably a good deal number more are eligible for Medicaid but not enrolled. Medicaid is a redistributive program. It redistributes income from high-income people to low-income people, from high-income states to lower-income states. This shows the share of state residents with low incomes across states. And the way that Medicaid redistributes income is through the federal match. So Medicaid is jointly financed by the federal government and state governments. And the percent of costs covered by the federal government varies from state to state depending on the level of poverty, on the socioeconomic status of the state. So for example, in West Virginia, that federal match is almost 75% compared to higher income states where the federal match is closer to 50%. So not surprisingly, Medicaid plays a really important role in state budgets. It used to be for a long time the biggest single item in state budgets was education, and now that's been eclipsed by Medicaid, in part because of the continued rise relative to inflation in healthcare spending. So over on the left, you can see almost 25% of total state spending is on Medicaid, including the federal funds. As a share of state general revenues, it's a little bit lower, about 18%, and it accounts for almost half of all federal funding coming to the states. So it's an important driver not only of health, but of the overall economy of states. And in terms of who's covered by Medicaid and where the money goes, this shows for West Virginia Medicaid post-expansion that non-disabled adults and children account for about 74% of all enrollees in West Virginia Medicaid, compared to the elderly and disabled, who make up about 25% of all enrollment. But when you look at the expenditure side, those ratios are flipped. So 26% of enrollees account for 61% of costs. So that minority of enrollees with disabling conditions and the elderly who may be in nursing homes are really driving most of the budget, if not most of the enrollment. Medicaid plays an increasingly important role in social determinants of health, which obviously, sitting in a school of public health, we all should be attentive to. And Medicaid policy has been, I would say, shifting more and more in the last couple of years to pay attention to social determinants of health, whether it's housing or transportation or other aspects of poverty and income and social supports. And the ways that Medicaid programs do this, sometimes they will put incentives in their managed care contracts to fund services and programs that address social determinants of health. And in other cases, Medicaid programs are directly coordinating with agencies that meet these needs, sharing data and trying to manage the populations. West Virginia, Medicaid sits in the Department of Health and Human Resources, which also houses many other social service programs, and so that coordination and communication role is very important. All right, so to sum up this sort of very brief 5 or 10 minute overview of what is Medicaid and why should we care about it. It's a large income-based program that covers about 74 million Americans, plays a particularly important role for some vulnerable groups in society. It's a major source of financing for community health centers, hospitals, and other parts of the safety net. It's a redistributive program, and it accounts for a large and growing share of state budgets. Medicaid spending is concentrated in a small group of beneficiaries, and social determinants of health are a major focus of policy. I want to shift now to talking briefly about some variation that we see across Medicaid programs. As I mentioned, the federal government sets out broad rules under which Medicaid programs have to operate, but then gives a lot of discretion to state governments to decide how it will run these programs. So, for example, states have to cover all of the healthcare services on the left side of this slide and can choose to cover the services on the right side of the slide. So you'll notice way up at the top under optional benefits are prescription drugs. Not required for states to cover prescription drugs under Medicaid. All programs do cover them, but some states place limits. You can only fill 3 prescriptions a month, or other limits on prescription drugs. Dental services, an optional benefit under Medicaid. Rehab, physical occupational speech therapy, hospice services, a long list of optional services that states may choose to cover. Coming back to the opioid crisis and the role that Medicaid plays in financing substance use disorder treatment, this shows some of the variation across state Medicaid programs in evidence-based therapies that are covered. So the gold standard in terms of evidence for treatment of opioid use disorder is medication-assisted treatment, either with methadone, buprenorphine, or naltrexone. And you can see only 36 states cover methadone. I think West Virginia added methadone to Medicaid coverage just recently. All states are covering buprenorphine, although there's a lot of variation across states in whether there are limits or restrictions on prior authorization for buprenorphine. And then over on the right side of the slide, you can see the number of states covering things like inpatient detox, partial hospitalization, peer support, and other services. And these differences in the benefits and services covered across state Medicaid programs have consequences for spending, which is just a rough measure of the generosity of a Medicaid benefit across states. And so you can see over on the left side, total expenditures per Medicaid enrollee varies from a low of about $4,000 in Nevada up to $10,000 in North Dakota, and then it differs across different eligibility groups. Children are relatively inexpensive to cover. Individuals with disabilities and aged populations over on the right, much more expensive, but you can see the incredible range across states in expenditures per person, and that reflects the variation in the state level in the generosity of the benefits and services. And also the amount paid to providers. That's just another thing that Medicaid programs have discretion over. So one question that people have had in this realm of Medicaid policy research and Medicaid services research is, can Medicaid programs be a laboratory? Before we make a big move at the federal level, in the Congress, to expand Medicaid or to change Medicaid in some way, can we learn from the experiences of all of this variability across states? And this was, as far as I know, the first person to articulate this notion of states being the laboratories of democracy was Chief Justice U.S. Supreme Court Justice Louis Brandeis in the early 1930s. A state may, if its citizens choose, serve as a laboratory and try novel social and economic experience without risk to the rest of the country. And so I'll just kind of let that question percolate with you. Do we have an environment in terms of Medicaid policy making at the state level that allows for us to learn, share lessons across states? Okay, so what is the state of evidence-based policy making in Medicaid currently? State Medicaid programs, and I think Dr. Becker will expand on this later in his comments, have a number of different sources of evidence and analytic support to make decisions. And they have a lot of decisions to make about who to cover, what to cover, how much to pay for things, whether to place limits, how to contract with managed care organizations and providers. So some state Medicaid programs have their own in-house analytic groups. They have data analysts, data scientists, economists, statisticians who can work with their own data systems. Although in most states, those analytic groups are relatively small and a bit limited. They can call on national associations who might have evidence to bring to bear. Consultants, a lot of money is spent on consultants in state Medicaid programs, think tanks, other evidence generators at a national level are important sources of evidence for Medicaid programs. And what's left off this list? You guys. Universities, which in my humble and unbiased opinion, are the best sources of evidence for Medicaid programs. You at WVU and we at Pitt and other large state-based institutions have a wealth of clinical, policy, programmatic, scientific expertise to bring to bear. The question is, how do we make that relationship work? How do we bring policymakers in state government and researchers together and get them focused on the same set of questions and problems? So I wanted to share a little bit about our experience at the University of Pittsburgh with our Medicaid Research Center and our collaboration with Pennsylvania Medicaid, which I know has some real similarities in terms of the work that WVU is doing with West Virginia Medicaid. So we started working with Pennsylvania Medicaid about 7 or 8 years ago, working with their claims, encounter, and enrollment data, trying to answer questions of interest to state policymakers around antipsychotic prescribing to kids, around opioid prescribing. This is when the state was really trying to understand what was driving the epidemic. And we started we put together an intergovernmental agreement. University of Pittsburgh is actually an instrumentality of the state or of the Commonwealth of Pennsylvania. And we have a relatively broad scope of work. And I've just provided an excerpt here for our mission. The University of Pittsburgh will assist Department of Human Services in monitoring and evaluating changes in health insurance coverage, access to care, health care, Medicaid financing, state and federal policies, regulation, legislation affecting health care and quality of health care delivery in the Commonwealth's Medicaid program. And when my institute director first showed me this language, I had heart palpitations. I thought, you have promised us to do what? This is an incredibly broad scope of work. If you think about how narrow, a grant application might be with very specific research aims, this can encompass almost anything that we do in public health, health services research, and health policy evaluation. And so it has been quite broad in terms of the number of projects that have come our way. This is a short list of some of the research projects and program evaluations that we've engaged to do for Medicaid in Pennsylvania. We're currently working on a large 5-year evaluation of the Community Health Choices program. That's the SHIFT in Medicaid of long-term services and supports out of fee-for-service reimbursement with a combination of financing Medicare and Medicaid to managed care contracts where the managed care organizations are at risk. We've done some analyses looking at hepatitis C treatment when the Commonwealth was trying to decide how to cover these new expensive medications, which had a price tag of $84,000 per course when they were first introduced. Who should they cover these medications for? And there's been some change over time in the prior authorization criteria. We've made some advances on helping the Commonwealth project eligibility and enrollment trends. We've evaluated the impact of, or are in the process of evaluating the impact of permanent supportive housing for people with disabilities on healthcare use and expenditures. On the reproductive health side, we've examined use of long-acting reversible contraceptives. And finally, we've done a lot of work examining the quality of opioid use disorder treatment. And I'll just give some examples of some of the opioid-related work we've done. Focusing on identifying high-risk opioid use, measuring the quality of treatment, engaging high-risk enrollees in medication-assisted treatment, and finally boosting the supply of MAT providers in rural counties. So in terms of identifying high-risk opioid use, we used the Medicaid data in Pennsylvania to measure the prevalence of 3 indicators introduced by the Pharmacy Quality Alliance. These are focused on high dosage opioid use, multiple providers, that's filling opioid prescriptions written by 4 or more prescribers and filled at 4 or more pharmacies, and concurrent use of prescription opioids and benzodiazepines at the same time, and looked at trends over time. And we're using this as a sort of starting point for doing some risk prediction work using machine learning tools to try to predict opioid overdose on the basis of indicators like this and about 200 other indicators we can measure in claims data. So this just shows the prevalence over time for these high-risk opioid measures, 30%. Down to 26% of Medicaid enrollees had concurrent use of opioids and benzodiazepines, which is a high risk for overdose. The multiple providers rate, as you see in the orange line, has declined pretty significantly from 2015 to 2017. It might have something to do with the imposition of a prescription drug monitoring program in Pennsylvania in 2016. And finally, the high dosage measure, that's actually something that's been creeping up a little bit over time. So this is valuable information for our Medicaid agencies to communicate to managed care organizations, providers, et cetera, on the quality of opioid use. In terms of the treatment side, we've spent a lot of time trying to measure the performance of opioid use disorder treatment. There's been a huge focus at the federal level and the state level on expanding treatment for opioid use disorder. Less attention has been paid on actually measuring the performance, outcomes, the quality of that treatment. So we started by just looking at, what are rates of treatment with buprenorphine, and we saw a pretty significant increase from 2007 through 2012 in the number of people enrolled in Pennsylvania Medicaid who were treated with buprenorphine. And then we looked at, okay, what percentage of those individuals had a diagnosis of opioid use disorder? And it looked like only about 75% of people filling prescriptions for buprenorphine had an opioid use disorder. And the state was very concerned at the time about the prevalence of cash clinics. That is, providers accepting cash from a low-income Medicaid beneficiary for the doctor's visit in exchange for a prescription that was then reimbursed by the Medicaid agency. And then we went on to compare some indicators of quality of medication-assisted treatment between those who didn't have an opioid use disorder diagnosis and those who did, potential marker of cash clinic use, and we see pretty big differences in terms of some of these indicators. So only 9% of those with no opioid use disorder diagnosis received any behavioral health counseling. Only 22% had any urine drug screen over the course of a year, compared to 52% and 74% of those with an opioid use disorder. And these and other indicators that we applied to the Medicaid data have been used by Pennsylvania Medicaid agency to monitor the quality of their Centers of Excellence program, their hub and spoke model for expanding treatment access and quality to opioid use disorder. We also did some research looking at particularly high-risk enrollees and their likelihood of receiving medication-assisted treatment. And our starting point, our premise for this research was an often quoted number that for every fatal drug overdose, there are 30 non-fatal drug overdoses. Have you heard that number before, the sort of tip of the iceberg? Non-fatal overdoses, many of which are treated in hospital settings, are really a window of opportunity for the health system to intervene. And the health system can intervene in a couple of different ways. It's an opportunity for providers to potentially reduce excess opioid prescribing. It's also an opportunity, so that's sort of taking something away. It's also an opportunity to bring something to the patient, and that is a referral and engagement in addiction treatment. And so we were interested in understanding the extent to which those changes were happening. So we collected data. We had 6,000 Medicaid enrollees who were observed in medical claims to have had a non-fatal overdose for opioid or heroin. And we looked at the change in medication-assisted treatment, opioid prescribing in the 6 months before that non-fatal overdose and the 6 months after. And any guesses about what we found? Not much change, yeah. A little bit in the right direction, but not much. And potentially not surprising given what we know about the ability for different providers to share information. So we start with 2,000 Medicaid enrollees who have a heroin overdose that's treated either in a hospital admission or emergency department visit. Among these individuals, before the overdose, 43% filled at least one opioid prescription, and 39.7% filled an opioid prescription after the overdose, resulting in a 3.5 percentage point decline. So again, moving in the right direction, but only by a teeny bit. In contrast, actually far fewer people who experienced a heroin overdose were receiving any medication-assisted treatment with buprenorphine, methadone, or naltrexone. It went from 29.4% before the overdose up to 33% afterwards. So nothing to write home about, not a massive mobilization of the health system in response to this life-threatening event. Similar story on the prescription opioid overdose side. We go from 66% filling an opioid prescription before the overdose to 59.6% afterwards. And you know, the bottom line is you're 4 times more likely to fill an opioid prescription after an overdose than you are to engage in treatment. That's a problem, and there's some room for improvement there. And this research has informed an effort by the state Medicaid agency to give grants to hospitals to build programs and systems to facilitate warm handoffs for people experiencing overdoses who are treated in emergency department settings to facilitate their connection to addiction treatment in outpatient settings. And finally, we did some very basic descriptive analyses of the supply of medication-assisted treatment providers, largely primary care physicians, across the 67 counties in the Commonwealth of Pennsylvania, We found that 11 counties didn't have any buprenorphine prescribers at all. 19 counties lacked a buprenorphine prescriber who was a primary care physician, and this was a particularly problematic undersupply in rural counties. So as a result of this, we helped the state write a grant to the Agency for Healthcare Research and Quality to fund RAMP, which is an intervention and evaluation program to try to recruit primary care physicians in 22 rural counties in Pennsylvania to become trained in delivery of MAT and provide ongoing support and education for those providers. Okay. So I want to, now that I've given you a little bit of an overview of some of the work we've been doing in conjunction with Pennsylvania Medicaid, I want to shift gears a little bit to talking about and reflecting a little bit on what makes these partnerships work and what might get in the way of a functional collaboration between university and a state agency. And I didn't actually have to do much thinking because I found this article that kind of perfectly summarized some of the issues that we've grappled with. There's a large, although I would argue not large enough, literature on barriers to evidence-based policymaking and on the problems that arise in translating policy-relevant research for policymakers. So this particular article, Researchers and Policymakers, Travelers in a Parallel Universe, I think sums up some of the challenges here. And I just wanted to draw attention to a couple of the things in this table where they're kind of comparing, you know, this is the orientation of researchers, and this is how policymakers think. I think the major incentives are quite different. We in academia think about measuring performance on the basis of how many grants did you secure, how many papers did you publish. Policymakers might think more about re-election, continuing to stay appointed. They might think about the budget of their agency. The connection with advocates might be very different between researchers and policymakers. Another big one, willingness to accept uncertainty. Researchers like to think about confidence intervals, and policymakers like to think about point estimates. We want to characterize all of the messiness and uncertainty around the particular policy issue, and policymakers have a binary choice to make. Yes or no? Tell me what the answer is. I don't want, it could be 50% or 80%. Let's meet somewhere in the middle. That's a very different orientation. The types of data relied on might be quite a bit broader in the policy-making realm than what we would consider. And another huge difference in orientation and just sort of ways of conducting research is the time frame to action. So we like to think in academia, particularly in health sciences schools, about the lifespan of a project being 5 years, maybe 7 or 8 if we get a renewal. Does that work for policymakers? 1 year budget cycle, 5 or 6 month legislative session. We need the answer in 2 months in order to actually make a difference. So there's a lot of bridging that needs to happen between these two worlds in order to make the partnerships effective. All right. So I gave you a little bit of an overview of some of the work we've done in Pennsylvania, and all of that has been very Pennsylvania focused. And I've written lots of grants and papers that argue Pennsylvania is average. We are just right down the middle of the road in terms of urbanicity and demographics and income, et cetera. We're representative of the entire United States, not really. There are a huge number of limits to this sort of one state at a time approach to Medicaid research. The first of which is we're very limited in our ability to infer causal relationships between the interventions we're evaluating and the outcomes that we care about. What's the counterfactual? What would have happened in the absence of this particular policy bundle that the Medicaid agency put into place? And unfortunately, other comparators like Medicare populations and the commercially insured are not a good comparison for very low income people. So the next challenge is generalizability. And it's the old adage of you've seen one state Medicaid program, you've seen one state Medicaid program. How do we generalize what's going on in West Virginia or Pennsylvania to what's happening in Oregon or New Mexico? Not going to work. And unfortunately, there are very few sources of data for multi-state Medicaid work. Not all states have all-payer claims data sets, as we were commiserating this morning. MAX files, which was the research files that researchers would obtain directly from the federal government through a contractor. The most recent year available is 2014, not very helpful. The federal government promises a new source of research files for Medicaid maybe sometime this year, but they've been saying that for the last 3 years consistently. We'll see what happens. So coming back to Justice Brandeis's comment about a laboratory for democracy and using the variation we see across state Medicaid programs, how do we actually do this? Okay, so for that, I wanted to shift gears again and talk about some multi-state work we've been trying to pull together with our partners, Academy Health, which is kind of the professional society for health policy research and health services research with about 4,000 members nationally. And we've been at this work with Pennsylvania Medicaid for 7 or 8 years. We thought we were very special and unique. That we were the only university researchers doing this kind of work. And then we quickly learned we're one of 27. That actually multiple state universities have partnered with their Medicaid agencies across the country to conduct policy-relevant research. But until relatively recently, these universities were not really coordinating with each other. They were working in isolation. So what we've launched over the last year or so is something called the Medicaid Outcomes Distributed Research Network, or MODERN, thanks to Nathan Pauly for the name. It builds on 2 existing professional networks, the State University Partnership Learning Network, which is all of these state university partnerships, and also the Medicaid Medical Directors Network. Most states, I think about 45 state Medicaid programs, have a clinical leader or multiple clinical leaders, chief medical officers, who evaluate evidence and inform policy decisions at the state level from a clinical perspective. And those individuals have a professional network that's quite vibrant and long-standing. What we tried to do is to take these 2 networks and create a distributed research network. And as we were building this thing, we looked at what are the existing distributed research networks that we can learn from. So PCORI, the Patient-Centered Outcomes Research Institute, has something called PCORInet. They have a lot more money to play with than we have. And the FDA, in an effort to improve post-marketing surveillance of prescription drug safety, started something called the Sentinel Initiative several years ago, where they linked together data for about 110 million people, not by sharing individual level data, but by using this distributed research network framework. And I'll just quickly walk through the functions of a distributed research network and how we've applied those functions to our world. So the universities in MODERN who have access to their state Medicaid data have transformed their Medicaid claims and enrollment data to a common data model format. It just means a common template. All of the analyses of state Medicaid data are conducted locally by each university. So what does that mean? We don't have to have many lawyers involved in this effort. There's no row-level data sharing, no individual level data sharing, no identifiers. It's just aggregate results that are being shared, and that obviates the need for data use agreements and lawyers. We have a data coordinating center for this project where we develop specifications for variables. We develop SAS code that we distribute to each of the university partners where it's executed locally. This leads to standardized and efficient analyses. And each university provides results, not data, back to the data coordinating center, but only after they've gotten their states to review the results first. Okay, So as we were building this distributed research network, we needed a specific project to hang on to. We didn't just want to build a common data model. We wanted to answer some questions of importance to Medicaid programs. And so we started with the opioid epidemic. It seemed like an obvious choice given Medicaid's role. We launched Modern, Examining the Quality of Opioid Use Disorder Treatment in November of 2017. We have 11 states participating in Modern so far, covering about 17 million Medicaid enrollees, accounts for 23% of all Medicaid enrollees nationally. And you can imagine that these are states that have been pretty hard hit by the opioid crisis. It includes, I think, 5 of the top 6 states in terms of overdose death rankings. Our objectives for this first opioid-related project, we had 5. We wanted to advance performance measurement for substance use disorder treatment, which really lags behind the rest of medicine. We wanted to examine state-level differences in opioid use disorder treatment, rigorously evaluate the impact of policy changes, share best practices across states, and finally to develop infrastructure for use in future projects. So I just wanted to show you a few results just to kind of whet your appetite and think about what's possible with this distributed research network framework. And I've masked the identities of the states participating in this effort down below. So this is the prevalence of opioid use disorder diagnosed. So it's just scratching the surface of the total prevalence in Medicaid enrollees. And you can see it varies pretty dramatically across states. I will say that State C and State G did not expand Medicaid. So there's a whole untapped, unmet need in those states not being met by Medicaid. We looked at rates of medication-assisted treatment among those diagnosed with opioid use disorder, and you can see the variation across states. When we showed these results to our Medicaid medical directors, there were a lot of questions to State B. What are you doing to have rates of treatment so much higher than the rest? We also looked at another indicator of quality of medication-assisted treatment, that's continuity of pharmacotherapy. What is the proportion of Medicaid enrollees treated with medication for OUD receiving at least 6 months of treatment? And you can see the variation across states from about 45% up to 66%. We also, because Medicaid Plus plays such an important role in covering pregnant women with opioid use disorder and infants diagnosed with neonatal abstinence syndrome, we also measured the prevalence of NAS and applied different definitions, both sort of broad and narrow diagnostic criteria to measure the prevalence. Among infants diagnosed with NIS, we also looked at the percent receiving the recommended number of well-child visits in the first 15 months of life. Infants are supposed to get 6 well-child visits. You can see from these results that only about half of infants across the board diagnosed with NAS are receiving that recommended care. So that's just a small smattering of results from our multi-state work from Modern. And where we're trying to go next with this project is to try to understand what are the policy drivers or health system features that might explain some of the variation we see in these outcomes. So we've already talked about Medicaid expansion. Might methadone coverage by state Medicaid programs drive some of these differences? Prior authorization criteria for buprenorphine, the ways in which we license substance use treatment providers, and so on and so forth. There are about 1 million policy variables that we could consider here. So I'll sort of leave you with my Modern pitch in terms of our value here. What we're trying to do is build on these established trusted relationships between state policymakers and researchers and Academy Health, it's a central convener. Engage researchers who play a central role in Medicaid data analytics. Generate research focused on bringing evidence to Medicaid policy and practice, so these important decisions aren't made without evidence from their own data. and allowing Medicaid agencies to try to benchmark their progress and their performance against their peer states. And finally, to try to create opportunities for rigorous policy evaluation. So to summarize, and then we can move on to your questions and comments and then the other two speakers. Hopefully I've left you with a sense of the role that Medicaid plays really as the backbone of our safety net, as a major source of financing for our safety net. Medicaid programs vary significantly in who they cover, what they cover, how much they pay, and so many more other domains of policy. Universities can provide an invaluable role for Medicaid policymakers, and I think we have almost unlimited potential there that has yet to be realized. And finally, that a Medicaid policy laboratory is very much under construction, and hopefully we'll have more to report in the coming years. So with that, I will say thank you and open it up for questions. Yes?
I'm kind of curious about why they set it up so that you had some required benefits and optional benefits. Because it seems like as citizens of one country, we should have the same benefits.
Don't get me started. Yeah, so so I think there is this tension, and the tension plays out differently from one administration to the next in terms of how much federal guidance / rules and restrictions to place on states versus how much flexibility to give. The current administration, as you might imagine, is very pro-state flexibility. Each state should determine on its own what's right for its citizens, what it can afford, what it values, etc. But yeah, this was the way Medicaid was structured back in the 1960s. It's sort of always been a component of the program that there's a lot left up to the states.
It relates to that. Why is it that the Medicare program for the elderly was so much centralized with a lot of quality controls and a whole strong own research base, and the Medicare system is so fragmented? I don't understand the history of how those sort of came to be so different.
Yeah, so it's a really interesting question that there are so many interesting differences between Medicare and Medicaid. My understanding of the history and the congressional debate was that Medicaid was a bit of an afterthought. That the primary population the Johnson administration was trying to meet the needs of were older people. Medicaid programs were added into the legislation and have evolved over time to take on more and more sort of niche populations, and had, until the Affordable Care Act, very patchy eligibility rules. So you had to be low income and pregnant, low income and disabled, low income and AFDC or TANF recipient. It wasn't just a straight income eligibility criteria, and it wasn't a universal program like Medicare was. And this decision to make it a state-federal partnership from the very beginning set up this potential for variability across states. Yeah. Not a satisfactory answer to your question probably, but it's a historical accident, I think. Yeah, Jim?
Dr. Donahue, I'll address
that. Okay, good. Perfect.
Not now,
but in your remarks, excellent.
One of the other things, could you discuss a little bit more the different, I know you've done some work on hepatitis C, and the differences in the treatment across different states, and any work that you're doing now with this partnership on hepatitis C treatment?
Sure. So we, states have generally, on average, expanded the scope of eligibility for hepatitis C treatments. They started with, fibrosis scores of, 3 and 4, and have gradually, as they've gotten, as the prices come down, as they've negotiated rebates, and as they've realized that even if we expand coverage and loosen prior authorization criteria to bring in everyone diagnosed with HCV. We're not breaking the bank yet. That's how things have gone, and I'm sure Dr. Becker can speak to that in even more detail. But there hasn't been that much multi-state work to examine differences across states, and I think it's a huge potential for our network. Lindsay.
I think one thing we've gotten really lucky with WVU and our partnership with this state, and I would say this even if Dr. Becker were not sitting in the front row, is that they have not at all tried to control our messaging when we're publishing abstracts. And you mentioned that you had a similar experience with relationships with the Commonwealth. In cases where that isn't so easy, how do you help reconcile the different incentives that you showed on that kind of table from the article?
Good question. So I think you have to be willing to invest the time in building the relationship, in developing a shared understanding of what's the end goal of the research, where are we trying to go, what are the policy implications, what can we do with the information. It would be, I think, a huge mistake for researchers to take the data, go off and run their analyses, and come back 2 years later with a fully written 3,000-word article. And say, we have to get this to press in 2 weeks, or we have to get this to the journal in 2 weeks. That's not going to fly well with people who are charged with managing these incredibly complicated and incredibly political programs. They have to deal with overseers in the legislature. They have to deal with governor's office. They have to deal with huge advocacy communities that are paying attention to what they do. And so I think being in touch and communicating at every step of the research process is really important, so that nobody is caught off guard about what we think the conclusions from the data really mean. Yeah.
Is modern associated with advocacy or making policy?
Not at all. Not at all. And I think university researchers have, there are big debates within universities about how closely aligned one should be with advocates. Is advocacy a sort of dirty word or not? Do you lose your objectivity if you come down on the side of a particular policy stance? Or are you appropriately disseminating your research findings and thinking about the policy implications of your work? For our purposes, for building the network, and really for maintaining this relationship with the state agency, we've really kept any advocacy organization at arm's length. And we're helped by the fact that under the terms of our agreement, we can't share data with any outside group, including a journalist or an advocate or anyone, without clearing it with the state first. So I think that's helped a little bit. Does that answer your question? Okay.
Julie? Bring her back up here in a moment, but next I want to ask Dr. Polly to provide an overview of some of the work that we've been doing with West Virginia Medicaid, and Dr. Becker to comment on that as well.
Great. Is this on? Can everybody hear me? All right. Well, thank you for the introduction, Jeff, and thank you very much for the presentation, Julie, and giving us such a great overview of why Medicaid is so important to maintaining the safety net and how these state-university partnerships are so important to informing Medicaid policy. And so now that we've developed some common understanding of what these state-university partnerships are and why they're so important, I want to spend a few minutes talking about some of the specific initiatives that we are engaged in with West Virginia Medicaid in Charleston. So over the last year, we've had 7 different projects that have been directly funded by West Virginia Medicaid, and I would very broadly and generally classify these projects into 2 separate groupings. So one being very targeted, specific forms of program evaluations, and the other group being more general forms of kind of research and decision support assistance that we provide to Medicaid. And so what do I mean exactly by program evaluations? So as we know, Medicaid is one of the most important funders for healthcare services in the United States, and every Medicaid program has this standard set of services that they provide, as well as some optional services. Now, in addition to those standard sort of suite of healthcare services that these Medicaid agencies provide, Medicaid agencies also offer a lot of special programs for particular subsets of the beneficiary population. These programs may be initiatives that are testing new methods of delivering care to certain populations. These may be initiatives that are exploring different payment models for different types of service, or these may be even initiatives that are just providing a specific suite of services to a particular subset of the population that is at high risk or is a vulnerable population. And so Medicaid agencies spend a lot of money on these programs, and these programs impact a lot of people. And so from a programmatic perspective, Medicaid has a vested interest in taking a look back at these different programs that they're operating and seeing whether or not these programs are achieving the intended outcomes of improving different health outcomes, and whether or not by improving health outcomes, these programs are actually saving the Medicaid agency money, or at least not losing a lot of money. And so Medicaid agencies have these very important questions about their programs, and they have a vested interest in answering them, but they don't always have the workforce on staff who have the experience or the skills or even the time to design and implement a really robust evaluation of these different programs that they provide. And so that's where we come in. So that's when they contract with us to go in and look at their data and tell them whether or not the program is working how they want to be working. So I don't have time to go through all of these, but just to highlight a few of them. One of the ones that we've been really involved in over the last few years in an effort led by Drs. Bias and Dr. Lindsay Allen with the School of Public Health is an evaluation of the state's 1115 substance use disorder waiver. And so now everyone in this room, I'm guessing, is aware that West Virginia has been at the epicenter of the nation's opioid crisis over the last few years. And West Virginia Medicaid, as we know from Dr. Donahue, is one of the most important providers of healthcare services for individuals with opioid use disorder. And now, formerly, Medicaid covered a lot of different types of treatment for substance use disorder and opioid use disorder, but we didn't cover all types of treatment. And so under this 1115 waiver program, we are trying to open up the entire continuum of care for substance use disorder, and we are implementing new services for Medicaid beneficiaries that were not previously available. And so we are conducting a 5-year longitudinal study where we're 1 year in, and we're looking at whether or not access to these services is impacting opioid-related outcomes. So like number of individuals dying from opioid overdoses, hospital admissions related to opioid use disorder, et cetera. And we're going to be looking at how these outcomes changed before and after implementation of this waiver. And hopefully we'll be able to demonstrate that improved access to these services has improved health outcomes and eventually saved the Medicaid agency money. Another evaluation that we've been really heavily involved in the last 6 months or so, and an effort that I'm leading, is an evaluation of the Medicaid agency's diabetes health home program. So health homes are a form of integrated care management for patients with multiple chronic conditions. So in Medicaid here in West Virginia, we have a health home for individuals who are diabetic or pre-diabetic who also suffer from depression or anxiety. And the idea being that if we can provide better integrated care management in terms of integrating physical as well as behavioral health care, that we can eventually improve outcomes in these complex cases and eventually save the Medicaid agency money. So we are doing this as sort of a mixed method study where we are using Medicaid claims data to go in and look at health outcomes as well as changes in spending before and after this program was implemented. And we're also conducting focus groups with actual clients in the programs to learn more about how the programs have impacted their sort of diabetes management. And I just want to say how great it is to be involved in all of this kind of work because, I mean, as Julie said, this kind of research is going to have a real-world impact on real people in a very short amount of time. So like this diabetes health home program evaluation that we're working on, this program is currently operational in 14 different counties in the state. And at the conclusion of the pilot period later this year, Medicaid's going to make a decision whether or not they want to expand the program statewide or whether or not they want to cut the program. And they're going to use the results of our evaluation to help guide that decision making. So I can't say enough about how exciting it is as someone who's interested in research and interested in methodology to be able to go in and apply those skills in such a way that it's going to have a real impact on people's lives. So in addition to these sorts of very specific targeted program evaluations that we work on, we also provide a lot more sort of general forms of research and decision support to the Medicaid agency. And just to give you a sense of what this may look like, one of the efforts that we were involved in a couple months ago is an effort led by Josh Austin with the School of Public Health in coordination with some of our colleagues in the College of Business, where we went in and helped Medicaid develop a strategic plan. And this was something that was really interesting because we learned doing this that prior to this, Medicaid had never actually had a formal strategic plan on paper. At least they didn't have one that had been current in the last 10 years or so. And so it was really interesting, you know, being a part of this university that's interested in having a partnership with Medicaid, and Medicaid is so important to our state. It was a really rewarding experience being able to go in and sort of have a guiding hand in how this strategic plan was developed and how Medicaid agency developed their sort of vision and mission that's going to guide the agency over the next few years. So now these are all examples of projects that have been directly funded by West Virginia Medicaid. And so for each one of these projects, we have a very specific scope of work that lays out in detail exactly what the deliverables will be that we are going to provide to the state and exactly how much the state is going to pay us for each of those deliverables. And that kind of contractual relationship is great. It has a lot of benefits for both the state as well as for the university. But one of the things that we're interested in is moving this towards more of a fully fledged partnership. And in an attempt to move this towards being a more self-sustained, fully fledged partnership, one of the things that we've been working on is embedding personnel within the Medicaid agency. And so that's actually why I'm here. That's what I do. I am an embedded analyst with West Virginia Medicaid. So that means that I am employed by the WVU School of Public Health, but I actually work full-time at the Medicaid offices in Charleston. And so I have a little cubicle that's right outside the Medicaid commissioner's office. And what do I do there? I do a little bit of everything. So I've been involved in many of those initiatives that I showed you on that last slide to some degree or another, but there are also a lot of things that I work on that are not directly within the scope of any one of those particular projects. And sort of broadly, you know, one of the main goals of me being there is to help beef up the Medicaid agency's data analytics capacity. So again, Medicaid has a lot of data, and they have a lot of very important questions that they need to figure out using that data. But they just don't have the people on staff who have the appropriate training or have the time available to appropriately interrogate the data and answer these questions. And so that's where I come in. One of my main roles is in providing sort of ad hoc data analysis at the discretion of Medicaid leadership. And that takes a lot of different forms. So that may look like a few months ago, I put together some slides showing heat maps of rates of opioid use disorder and other conditions by county across the state that the Medicaid commissioner used to present to the legislature. A few weeks ago, the finance director at Medicaid came to me and said that they were interested in changing some reimbursement rates for particular services and said, here's all these services. If we increase reimbursement rates by 25%, how's that going to impact our spending on these services next year? And so I have the skills available that I can go in and appropriately interrogate the Medicaid data to answer those questions and to do so relatively quickly because, again, these are things that the Medicaid leadership needs answers to relatively fast, as we saw in Dr. Donahue's slides, that they're operating on a much faster timeline than sort of traditional research. In addition to doing this sort of ad hoc data analysis, I also work on the development of a lot of policy briefs or kind of white papers. And so again, this can be the Medicaid commissioner or someone else like Dr. Becker may come to me with a specific question, and I will spend some time doing an in-depth research of that question and sort of composing that in such a way that is approachable to people who may not be familiar with this kind of literature. And so this takes on a lot of different forms. It may be, you know, a few months ago, the Medicaid commissioner asked me about what other states are doing to change reimbursement rates paid to federally qualified health centers. And so then I do a very deep dive into the literature and put together some different options that other states are using that our Medicaid leadership may be interested in pursuing. Another example of this is just over the last few months, we've been working on putting together a Medicaid 101 manual that is sort of answering a lot of frequently asked questions about Medicaid services and shows trends in Medicaid enrollment and spending over time. And this manual was actually distributed to every member of the West Virginia legislature this session. So that was really exciting to be able to be involved in that kind of thing. In addition to providing sort of ad hoc data analysis as well as the development of these policy briefs and white papers, I also provide more sorts of general kind of project management assistance with applying for grants and technical assistance opportunities. So again, my sort of general goal in being there is to help beef up Medicaid's data analytics capacity, and one of the great ways to do that is to pursue technical assistance from external organizations. And so I help with I help them with identifying what some of these technical assistance opportunities may be, as well as submitting applications for them, and then continuing to be engaged as sort of a player once we get that technical assistance, and continuing to kind of consult with Medicaid leadership as well as with other people at the Medicaid agency about how to best apply that technical assistance in a way that increases our data analytics capacity. And last but not least, my job there is to serve as a liaison between WVU and DHHR. And so I know that everybody is always tired of hearing about how we work in silos, but in a state like West Virginia, where WVU and DHHR do share such a fundamental mission of improving the health of the state, but we're 2.5 hours apart. It's not always easy to talk to each other, but now I am there outside the Medicaid Commissioner's office every day, and this relationship works both ways. So it's now much easier for the Medicaid Commissioner or other leadership to approach me to see whether or not WVU would be interested in helping them apply for a grant, or whether or not they would be interested in being a care delivery partner for a special initiative they're doing. And it cuts the other way, where it's much easier for folks here at WVU to reach out to me if they need to know whether or not Medicaid would support them in a grant application, or whether or not Medicaid would be interested in a certain program that we are providing. And so again, I am sort of that point of contact that improves communication between both WVU and DHHR and allows us to both serve our joint mission better. So now I just have a couple minutes to wrap up here, and just briefly want to talk about sort of looking to the future. Where are we trying to expand this partnership, and what does all of this mean for folks in the audience? So I know that the focus of this presentation, on Dr. Donahue's presentation, has been about state-university partnerships as they relate to Medicaid. But the Department for Health and Human Resources is much bigger than just Medicaid. So one of the things that we're really interested in doing is expanding our partnership beyond just the Medicaid Bureau, and also working with the Bureau for Behavioral Health, the Bureau for Public Health, as well as leadership within the Secretary's Office of DHHR. So we've also been engaged over the last year or so in multiple different sort of contractual agreements to provide, again, program evaluations and project support assistance to the Bureau for Behavioral Health and the Bureau for Public Health. I'm very excited that last year we were also able to hire Angie Dyer, who's a PhD student here, who is now serving as an embedded analyst with the Bureau for Behavioral Health. And so she's kind of acting as my counterpart in that sister agency. And again, looking to the future, we're looking to continue to expand those partnerships beyond Medicaid, as well as begin to embed personnel in some additional bureaus within DHHR. Finally, what does all of this mean for WVU students and faculty? Well, the first thing that always comes to mind for me, because I'm a big data guy, is that this partnership has really opened up the availability of some tremendously rich data sources that can be used for research by WVU students and faculty. So I'm not sure how many folks in the room have worked with Medicaid claims data before, or claims data in general, but it is a tremendously rich data source that can be used to answer a lot of research questions related to healthcare policy, epidemiology, healthcare economics, you name it. If it's related to healthcare, you can often use claims to answer that question. I wrote my entire dissertation using not Medicaid claims data, but commercial claims data. So there's a lot of different applications for these data sources, and we have a relatively simple approval process to seek approval from Medicaid to use these data for independent research. So if this is something that you're at all interested in, I would encourage you to stick around after this session or come to our open session tomorrow morning, and we can talk a little bit more about what these data can be used for and how you can get access to them. In addition to this, our partnership has also opened up our access to a tremendous institutional knowledge base. So folks who have been working at state government for a long time often know a lot more about state government than we do at the university. And so if you're a health policy researcher and you're interested in the impact of some very nitty-gritty detail of a healthcare policy, and you need to know when that policy went into effect or when Medicaid started covering a particular service, that kind of information can be really hard to find if you're just going to a Google search. But if you shoot me an email, I probably don't know the answer to it, but I can almost guarantee you that I can find someone at Medicaid or someone at the state who does know the answer or can tell us where to find the answer to that question. Another opportunity for WVU students and faculty, we also know that we are going to have a great need for future program evaluations. So again, this can serve as a future source of funding for WVU faculty here, and also continue to benefit the state in terms of providing evidence to support their policies. And finally, we're hiring. So this is a shameless plug, but we are, again, interested in embedding analysts with different bureaus across the Department for Health and Human Resources. So if any of this sounds interesting to you and you could see yourself working in this kind of environment, or if you know someone who might be interested in working in this kind of environment, I would again encourage you to stick around afterwards and come talk to us, and we can explore some of those options. So, thank you.
Last but certainly not least, I want to invite Medical Director Dr. Jim Becker to comment on your perception.
Yeah, thank you, Dr. Coben. Can you hear me? I really enjoyed your comments. I had to rearrange what I was going to say in my brain because I thought it would be important to get a couple of questions answered that came up earlier with Dr. Donahue. So let me begin by saying that I've been the medical director at West Virginia Medicaid for 11 years. I think I'm the second or third longest serving medical director for a Medicaid system in the country. And it's a wonderful experience. I really love the work that I get to do there. And the work is highly varied. And the opportunity to work with a university, I think, is so important to the success of your Medicaid program. And that's part of why I was enthused when Jeff suggested that I come here for this colloquium, because this relationship is an extremely important relationship that we would like to see developed in a lot more robust way. West Virginia Medicaid now takes care of the health care benefits for about 520,000 West Virginians. So it's about 1/3 of the population derives health care benefits through Medicaid. And in answer to one of the questions that came up, there was a question about why limited services and why not a lot more emphasis on this as there had been with the Medicare system. Dr. Donahue is correct that this was an afterthought in 1965, really to add these services on for a certain segment of the population. And it was viewed as a temporary move. It was temporary coverage. It was always anticipated that individuals who needed this needed it because they were individuals of very few resources and considerable need. And it wasn't thought that they would always continue to need those services. And then it became obvious that there are certain segments of the population that do need this continuously. People with special situations. Take, for example, Lennox-Gastaut syndrome or Dravet syndrome, both pediatric conditions in which children have daily severe seizure disorder, never able to be gainfully employed, frequently not able to really be educated, and constantly requiring high-level medication. So patients like that were brought into the system. The patients with cystic fibrosis. You can just go down a list of all these people with great need and very little resource available to them. So I like the work that I do because I get to look at a lot of very complex cases and make decisions about things that we can pay for or not pay for. And so that gets to the other question that came up about why can't you just pay for everything? So I remind audiences all the time that Medicaid coverage, Medicaid benefits are benefits, not insurance. The patient receiving the services is not paying a premium. There is no money put aside in reserves. Nobody's investing the money on the side to try to add additional money back into an insurance system. Instead, in a system like ours, it has to balance in the budget every year. So the $1 billion, approximately $1 billion that comes from our legislature to pay for our portion of the money that's available for that health care benefit has to actually balance. So I'll give you two examples of where we make that decision that the university might have helped us with, or some part of it they might have helped us with. And the one is on a device called a sacral nerve stimulator. And these devices are fairly expensive, $35,000 device, and there is limited evidence about the effectiveness of that particular device for controlling incontinence. We can imagine that certain people who have incontinence, they really need help. They get put on a lot of medicines that are sedating. They may not be effective. And so we were asked some 5 or 6 years ago to take a look at covering these devices. So a process that we would do in our own office that would also be very parallel to what you could do here in public health would be to go and systematically look at the effectiveness of those devices and decide for which population they would be appropriate, how much they would cost, how often they would have to be replaced, who would place those devices, how you would track the effectiveness, how you eventually evaluate the return on the investment. And so in my office, the process that we would do would be to first benchmark the data. So we would pull data that relates to all the incontinence supplies and medications that we pay for. And then we would make a decision about that device and who should insert it. And then we would use that benchmark at a time as our reference point for deciding over some period of time how much potential savings there is in the system. We also go out and search our database to see how many people actually have incontinence that would qualify. And so this is the kind of research that gets done every day in our office by my small team of people with the help of WVU staff who are available to me, with Marshall's staff, and experts out in the community. So I talk to experts who might insert one of these devices or implant one of these devices. So this is the realm in which Medicaid work really happens. And every day it's a decision about whether something is evidence-based or not. The reason that we don't pay for just everything is that not everything is effective and not everything is cost-effective. And so in a budget that has to balance, we have to make value judgments. And the way we make those value judgments is to actually decide certain groups can qualify for certain services. And some states do this in a very robust way. The Health Technology Assessment Group in Seattle does this for a lot of devices. In Oregon, they use a scale, a 500-item scale that defines the services that you can get if you're a Medicaid-qualified individual. And they adjust that scale up and down depending upon how much money there is in the budget. So if you've got item 501, it might not be covered. But if the budget goes up and there's money to spend, then 501 might be qualified. So this is how the system works. I just think it's a good idea to understand how it all happens. And my intention in telling you that is to tell you how important it is to be able to handle the data. Not just the data for coverage, but for programs like our health homes, which Dr. Pauly's working on for me, and our 1115 waiver for substance use disorder. These are programs that really make a difference, and they make a difference in a short period of time. So in a lot of ways, they're more attractive to me than more basic research, and I think there's a lot of reward in it. The other thing I want to mention is my connection to the Medicaid medical directors and the state university partnership. This is a very valuable relationship. I don't know that I've run into too many of you. I think I've run into Cecil a few times and a few others in the room here in my connection with community medicine. But in the days when I was with community medicine, as just sort of a volunteer faculty, we did a lot of things with occupational medicine and environmental medicine. And one of the things that we run into there is the natural experiment. And that's what we get out of the data that Dr. Donahue is using, is we get an opportunity to do a natural experiment by pooling data from multiple states who implemented in various ways with different programs in place, and then take a look at it and say, what common factor do we have? Is it the 1115 waiver for substance use disorder? Is it the fact that you've got them all in tightly managed care? I don't want to take too much time. I want to stop because I'm sure we're about to run out of time, and I bet the audience has some questions to ask. Let me say I've gone completely off script. I just wanted to pick up on the comments from the other two and offer you some additional information that might inspire you. So thank you for being here this afternoon, and we're happy to entertain questions, I suspect. Right? Thank you.
Yeah, please invite questions for Lee and all of our speakers today. Well, okay, I guess I will.
I actually didn't have a question, I had a comment. Just my first activity at WVU was working with Medicaid on prospective reimbursement methods for nursing homes. And so I've used been involved with some of the claims analysis for many years. I'm really excited to see it evolve to this level. It's much more sophisticated than what we've done before. Much appreciated. A big benefit, I think, of the university and to Medicaid. Thank you for your efforts.
Thank you. Sir?
So Nathan, I remember when I first walked into this job and we were looking at hiring you, and I thought, oh, this is so overwhelming, embedding sort of a new grad into a state system, and you made it look so successful and so easy. What were some of the obstacles, though, that you could tell us about as we look to place other new grads into these positions? Because I think this is a way that we could really help with vacancy rate, and it would just be a great job source for new grads out of our program.
That's a really good question. So it makes me think about my first day on the job. I was sitting in Dean Coben's office, and we were kind of talking about how, I was going to be going to Medicaid for the first time in a few days. And I was saying, I really want to know what are some short-term objectives. What should I be working on the next few days? And I remember I said to Dean Coben, I don't want to find myself in a place where I'm sitting there and I don't know what I'm supposed to be doing. And Dean Coben said, he kind of smiled, and he said, Nathan, I think a big part of this job is going to be figuring out what you're supposed to be doing. And he was absolutely right. That was a big part of the job, was figuring out what I was supposed to be doing. And I think that at first, Medicaid also wasn't really sure. I mean, they had a lot of questions. They had these, diffuse questions and ideas for things that they wanted me to do, but they weren't really sure where to point me in the right direction. And I think now that I've been there for a while, we've gotten a much better sense for sort of where I fit into the things. And so it would be more clear for new people coming on where they fit in. And so the biggest challenge for me was kind of figuring out what to do. And I think that now that we've gotten that out of the way, it would be a lot easier for new folks to sort of, we know where they would fit in the system. And we could take a much more targeted approach to hiring people who fit well here or fit well over here. But it won't be so difficult to sort of figure out broadly what you're supposed to be doing. Dr. Becker, do you want to comment on my challenges?
Didn't I? I think I asked him what he was doing.
And he said figuring out what I'm supposed to be doing.
But honestly, you kind of start with a general conversation like that, and then suddenly he was getting invited to all the meetings. And then the nurse practitioner who works in my unit was inviting him to health home meetings, and he got engaged in that. And they begin to say, you know what, you're a person who might know the answer to this. How do we do this? And that's how it takes off. And Adam's been up there, right? A lot, yeah. And Josh, of course, has been around. So a number of you have already done this. But having him embedded and knowing he's in that little cubicle, just available to us, is very helpful.
Yeah,
and the cubicles are a little discouraging.
The cubicles are actually much nicer than they were at Kentucky Medicaid. So I'll say that. No, I think another challenge that I've run into, and I think that continues to persist, is that the job is a very dynamic one. So I'm not doing the same thing every day, which is on the one hand exciting, but on the other hand also very challenging, right? So it's not just data analysis, it's not just writing, it's not just going to me, it's different stuff every day. And there's some days where I spend all day very deep in the literature trying to learn about changes to FQHC reimbursement rates. And there are other days where I spend all day doing SAS coding. Other days where I'm in meetings all day talking to people about the importance of calculating rates rather than raw numbers. Sure.
So, question for Julie. As an educator, how do you think they should be training our graduates to be prepared to assume this kind of dynamic interaction?
It's a great question, Joan. So I think, as I told some folks earlier today, part of my mission is to train the next generation of Medicaid policy researchers. That researchers tend to go where the data are, and there have been real barriers to conducting work with Medicaid programs because of data barriers. So in terms of training, I think there's the policy context, the political context, the understanding the population that you're studying, understanding the various stakeholders involved, and then a huge part of the training, I think, has to be on this kind of communication and coordination and relationship building mode, which you don't really teach in graduate school as a matter of course. So.
I have another question about the whole difference in the reimbursement for Medicaid compared to those physician visits or practitioner visits in the, it's a problem throughout the country. It's not just a West Virginia issue. But for example, we've been talking to the local physicians down in Pineville and in the southern counties here, and they get $49 for a standard office visit, and the FQHC gets 150 odd or 180 odd for exactly the same physician type visit. It seems to me that that's a real barrier. I'm interested to know what some of the issues are involved in that and how those kinds of things evolve like that.
Well, Dr. Pauly is going to solve that for us.
That's why I was invested.
It is really, it's an issue that relates to HRSA's position on underserved communities and areas of need. And so when the maps were drawn up defining areas of need, HRSA felt that it would be important to give additional support to the practices that were meeting the need of that population. And in return, they set up a certain set of requirements, like a board made up of patients who receive care in that federally qualified health center. And that's quite different from a private practice of 1 or 2 doctors. And I experienced the very same sense that this is just not fair. I was in a 2-man practice in Huntington and seeing the FQHC down the street getting $200 per encounter, and I was taking care of all the most complicated patients, in my opinion. So I don't know where the solution lies on this. This is an important thing to guarantee that people have access to care, and it's different agencies of the government who are taking different positions on it and strategies, and until HRSA has some rethinking about how they're going to define need and areas of need, I don't know how you can change that.
So Dr. Barrier even to getting MIT behavioral services to the community.
Yeah, it's a huge issue. The reimbursement rates are a problem in every state, even the more generous states. The differential between Medicare, other commercial payers, and Medicaid is pretty steep. And the access standards that the federal government imposes are perhaps not stringent enough. So states can say, yeah, we're meeting our obligations in terms of network adequacy, the standards we have for our managed care organizations. We have enough providers, but it doesn't actually result in adequate access. The problem is when Medicaid accounts for 25% of the state's budget, that's where legislators turn if they have a budget constraint, if they're trying to save money. So no one is really looking to increase Medicaid spending in order to pay providers more. That's a real problem.
I have a question for you. As a health services researcher who works in many different countries, I'm always eager to know what are the things we can do to improve access. I know quality of care and cost is a barrier, but 50% of people that you showed did not even access some of those behavioral health counseling services. What about state B that was so much higher than the other states? I'm curious about that.
So without revealing the identity of state B, so I think state B has been at this longer in terms of having experienced an earlier wave of this particular epidemic and got organized around coverage of the continuum of services, training of providers. Reimbursement does tend to be higher for some services in that state, but even states that have gone to all lengths they can from a policy perspective still encounter stigma, not just among patients, but among providers themselves, perceptions that addiction treatment isn't as effective as other kinds of medical care, resistance from certain parts of the substance use disorder treatment community against medication-assisted treatment. There's a dogma there that has to be overcome. So I think that it's multifactorial, and there are some real limits to what policy interventions can do there.
I have a follow-up question. I work with community health worker models in different countries. I know when people are from the community and trusted members of the community, sometimes those kind of things also help. And have that been used in the
I think, I don't know that I could have a great enough understanding of that particular area of the literature to comment, but I would say in general, we have a lot to learn in Medicaid research from global health research. What is working in low and middle income countries and low resource settings to get the biggest bang for the buck, and how can we apply that to the Medicaid policy realm?
I'll just add to that there are some other existing initiatives that we're involved with that are facilitating peer support, recovery coaches, engaging with patients in emergency department settings, quick recovery teams, engaging with patients following non-fatal overdoses to try to enhance their access to services. And generally, those are folks from within the community, similar to that community health worker model. Yeah.
So I completely understand the kind of mutually beneficial relationship between states and universities and the partnerships that results from that. But do you guys see any role for other partners that are included in that? Is there any opportunity to include other stakeholders, like, for example, the community health workers, whatever that Ranjita was mentioning, or other individuals or groups that haven't even thought of?
I think there's not only opportunity for it, I think it's essential to the success of the partnership on both sides. And I mean, a lot of times those organizations are the ones who are really the boots on the ground. I mean, the ones who are actually treating the people. Like, Medicaid pays for the services, but we at the Medicaid office aren't actually, well, with the exception of Dr. Becker, who's a provider, we aren't actually providing the services. And so I think that including those people in what we're doing, whether it's, broad-scale idea development for how to implement a service, or whether or not when we're doing the evaluation of the program, we need to have that perspective from people to know that we're not imagining something or seeing something that's not actually there.
I agree with Dr. Pauly. I think one great example would be in incorporating the FQHC system into efforts to obtain more Medicaid research outcomes. And so they have large practice base. That might be a good group to involve. Maybe do it with the FQs statewide.
Sure, I'm curious what each of you up at night. That being said, as I looked at the data, they're particularly the expense of taking care of the elderly. And we know what's happened with our population both in Pennsylvania and in West Virginia. How do you start forecasting, both as a researcher and also as a policymaker, so that the states, making decisions in a coherent manner, or maybe a wise manner?
Since I have the mic, I'll start. My 3 o'clock in the morning wake up is about a variety of things in the Medicaid system, or even in my job at the university. But the Medicaid system, I'm particularly worried about the pediatric population in the face of all of the opiate issues that we're dealing with, the future for these infants that are born with neonatal opiate withdrawal or neonatal abstinence syndrome, and what that means for our future pediatric care and our educational demands for the state. That's a big worry. The second big worry is the aging population and the high rates of chronic disease in long-term care, and how we're going to meet that need in the future, especially as we run into a lot more expensive medications and new treatments and questions about how to manage those people appropriately. So these are my wake up at 3 in the morning worry.
And it's funny you asked that because we were just discussing this in a session before this, and I brought up what keeps me up at night, and it's totally different than what Dr. Becker just said. But thinking about state-university partnerships, and one of the sort of threats to the success of that partnership is turnover in key leadership positions. So we've established very close ties with the Medicaid commissioner and with Dr. Becker and other leadership at the Bureau for Medical Services, but many of these folks are political appointees. And there's, turnover in these positions is notoriously very high. And so if some of those folks leave, sort of where does that leave our state-university partnership? And so trying to position ourselves in such a way that the partnership doesn't just dissolve if some key person to it leaves.
I share that anxiety. Yeah, so the great thing is that we've, our Medicaid work is deeply integrated with our research, education, and service missions in our department, Health Policy and Management, and many other departments around the school. And what happens if that goes away tomorrow because the governor has changed and he really likes Penn Pitt's out or Penn State or any number of top-notch research universities in the state. So and the way to alleviate that anxiety is to continue to produce good work, to continue to try to be responsive to the needs of policymakers, and hopefully show that we add value.
So we'll all sleep well tonight. Well, I want to, again, thank all of our speakers, particularly Dr. Donahue from the University of Pittsburgh. Please join me in welcoming Dr. Pauly, as well as Dr. Becker. Thank them all for coming. This is really been a great session. I remind you all that we're going to continue in this room. We've got some opportunities for networking, and also tomorrow morning at 9:30. If you're interested in a trajectory in this direction, please join us. We'll talk more about opportunities. And Stephen has a gift for Dr. Donahue for a presentation as well.
So thank you from the School of Public Health for your presentation and talk. And as you mentioned, everybody, please stay afterwards for some food receptions and networking, and it's all going to be upstairs there. And for the food, and thank you again.
Thank you.
Thank you, everybody.